Praise the Lord. When I came back to Trinidad, continued with the doctor's instructions. There is no cancer. Thank God for that. I don't have prostate cancer at this time. So I urge all men listening to me, some from the assembly, some from other countries, I urge all men to get tested quickly. I'm not talking about COVID. I'm talking about prostate cancer. I urge all men, get tested quickly. If you're past 40 years old, go and get it. The Lord has brought me to 87 years, and thank God that it's not there. Praise the Lord for that. So God bless you, and thank you for allowing me to make a statement. God bless you.
And thank you very much, Pastor, for those enlightening words. I'm sure we have been encouraged in terms of being proactive in relation to prostate issues. At this time, I want to welcome Brother Taku Ramnarayan as he will introduce our presenter this evening. Brother Taku, go ahead.
Hey, good afternoon. Spotlight में हम बड़ा deep missing. Okay, good night, everyone. Before I proceed, I'd like to make an announcement. I realize we have crossed 500 participants, and the good news is that those who are unable to log on to this Zoom platform, they can log on to YouTube right now. We are streaming live, right? So that facility has been implemented. So you could tune into YouTube, you could pass on the message, and Brother Mason type in a message, and those who are unable to log on Zoom, the Zoom platform, they could get on to YouTube. We are streaming live. Okay, this afternoon without much any delay.
Excuse me, please. How do you get, which channel do you go to for the YouTube?
Cleon, is it? Really?
I have a number of men who are interested, so I just want to get that.
It's RevivalTime Assembly YouTube channel.
RevivalTime Assembly.
RevivalTime is one word.
Okay.
RevivalTime is one word. RevivalTime Assembly.
Thank you so very much.
I see someone put it in the chat there, so you can check it out.
Okay, so those who's interested in logging on to YouTube, it is available right now. Thank you all once again. So good night once again to all these.
Spotlight Taku.
But I see myself there now, next to you, David. So remember, I won't see myself fully. Okay? Ready to go, David?
Yeah, go right ahead, Taku.
Okay, good night, everyone, again. Our presenter tonight is Dr. Kirk Gooden. He is a consultant urologist at the Port of Spain General Hospital and also an associate lecturer with the University of the West Indies. He graduated from the University of the West Indies, Mona, in 1999 with a Bachelor of Medicine and Bachelor of Surgery. During his time at the university, he obtained several scholarships, including the Marcus Garvey Scholarship, a Canadian scholarship, and a Jamaican scholarship. After completing his MBBS, he did internship at the Kingston Public Hospital, Bustamante Hospital, and Victoria Jubilee Hospital in Jamaica. He subsequently went to work at Cornwall Regional Hospital in Jamaica, where he rotated through several specialties, including anesthetic and several surgical specialties, including general surgery, orthopedics, and urology, obtaining invaluable expertise. It was at this stage of his career where he fell in love with urology. In 2007, he traveled to Trinidad to commence the Doctor of Medicine in Urology program at the San Fernando General Hospital. In 2010, he subsequently completed the DM Part 1 exam and was awarded the British Journal of Urology International Scholarship. In 2016, he completed his specialty and was awarded with the Doctor of Medicine in Urology. He has authored and co-authored few abstracts and publications. He is a member of the Caribbean Urological Association, Trinidad and Tobago, Urological Association, Caribbean College of Surgeons, and an American Urological Association. Dr. Gooden has special interest in urology and endocrinology. With specialized training and expertise, Dr. Gooden provides medical and surgical treatment for disorders and diseases of the male and female urinary tract. These diseases include kidney, bladder, prostate, penile, and testicular cancer, urinary tract infection, erectile dysfunction, infertility, stone disease of the urinary tract system, enlarged prostate, and many other genitourinary disorders. He is happily married with 2 beautiful daughters. His great compassion is to bring healing to people and ultimately to the nation with the help of Almighty God. In his spare time, he enjoys cooking, watching sport, and spending time with his family. So I just give you a brief insight of the person, our presenter tonight, Dr. Kirk Gooden. So without any delay, I introduce Dr. Kirk Gooden to this afternoon.
All right, good night, everyone. This is a pleasure for me to be doing this presentation, and I look forward for this to be a very good night. I want everyone to feel extremely comfortable, and so that they could ask whatever questions that they need to ask. The purpose of this presentation is to educate and to inform, so that all of us will have a lot more information so we could make better decisions in the future. Now, I have a PowerPoint presentation, and so I'm going to ask if the person in charge of the Zoom would give me the opportunity to share my screen.
Ramaran, go ahead and make him a co-host.
Okay.
Just allow him to share the screen, Narayan. We need to make him co-host.
It's supposed to be there. Doctor, try and see if you could share.
Yeah, you can share without any delay.
Just give me a minute there, please.
One person could share without any problem.
Can you tell me this one?
The icon at the bottom of it on the taskbar.
Is it? Can you tell me if it's shared there now?
Okay, we are seeing, yes.
You see the screen?
Yes, yes.
Okay, all right, great. All right, so tonight's topic, we're going to talk about prostate health, and I'm going to be concentrating on slide here. Okay, good. It's moving. Right, good. Right, so the topic tonight, we're going to talk about prostate health, and we're going to be concentrating on prostate cancer as well as enlarged prostate. Right? Are you guys hearing me clearly?
Roasting is the key factor.
I'm getting a feedback. I'm getting somebody else have their mics on mute. All right, great. All right, so essentially, the first question is, what is the prostate? Now, the prostate is a very small gland, and it's located in the lower urinary tract, and it's just located under the bladder and around the urethra. I know this may be a very simple information, but it'd be a surprise. Only men have a prostate. Women don't have prostate. All right, and the prostate, the importance of it is that it actually produces a fluid, which is carries in the semen. And this fluid that it produces is actually very important in reproduction. It produces an enzyme that we call the PSA, and the PSA is an enzyme that actually converts the thick semen to fluid. So it makes it easier for the sperm to swim. So that's the importance of the prostate. The size of the prostate is about the size of a large walnut, or if some of you don't know what's a walnut, it's the size of a golf ball. All right, that's the size of the prostate, and it measures approximately 15 to 25 milliliters or gram. Now, as you get older, the prostate slowly grows as you get older. And this is just a natural event, and there's nothing that you can do to avoid this from happening. Now, this is a diagram here showing you exactly where the prostate is located. So I don't know if you're able to see my marker, but this is where the prostate is located, and it's just right under the bladder. And as you can see, what is very important, there is a channel that is passing through the prostate. This is a channel where the urine passes through. So you could understand if the prostate gets large, it can cause an obstruction to the urine flow. So, and that's the reason why this little organ causes so many problems. All right. And then this is another diagram, almost, well, close, looking a lot closer to how the human body looks. Again, you have the bladder here, and you have the prostate here, and you can see the channel passing through the prostate. Again, you can understand why when it enlarges, it will obstruct the channel. Now, what can happen to the prostate? Now, there are three major things that could happen to the prostate. Prostate cancer, enlarged prostate, another name for the enlarged prostate. We call it, most times you hear the doctors mention benign prostatic hyperplasia. That's another name for enlarged prostate. And the other common pathology or common problem is prostatitis, which is referring to inflammation of the prostate. Now, I'm going to spend more time talking about the prostate cancer and the enlarged prostate, and not the prostatitis, because these are big topics in itself. And prostate cancer, I mean, is a very, very important topic for us to talk about, as well as the enlarged prostate. Now, prostate cancer is a very big problem worldwide. Now, in America, it's the most common non-skin cancer in men, and it's actually the second leading cause of cancer-related death in men. 1 in 7 men born today will be diagnosed with prostate cancer in their lifetime. Now, in Trinidad, prostate cancer is the most common cancer. When you put all the cancers that affect women and the cancers that affect men, prostate cancer is the most common cancer of all cancers in Trinidad. And in 2012, there was a paper that came out that Trinidad and Tobago has one of the highest mortality in the world from prostate cancer. And the reason why this is the case is because we don't have an official screening program. So a lot of times when men present, they already present in an advanced stage. And I have a lot of horrible stories about men, young men, presenting already paralyzed from the prostate cancer. And this is one of the reasons why we are having such a discussion, so that men can get more information. Now, some of the risk factors for prostate cancer. Age is one of the most important risk factors. As you get older in age, you increase the risk of getting prostate cancer. So actually over the age of 50, your risk increases tremendously. And most prostate cancers tend to be diagnosed at around age 65. Now, prostate cancer is very rare in men younger than 40. I've never seen a man younger than 40 have prostate cancer. The youngest age that I've seen is age 45. Recently, I operated on a gentleman who was 48 years of age who had prostate cancer. And how we actually found out, because he was of African ethnicity. And so he decided to go get his PSA done. And when he did his PSA, unfortunately, the PSA was approximately 20. and he was the father of a medical student. And they were very surprised and amazed. But when we did the imaging, it was found that the cancer was localized. So we're able to, we do a radical prostatectomy, which is a surgery that we do to remove the cancer. And the gentleman is happy and is doing well. Now, the other risk factor, so age is one, the other risk factor is family history of prostate cancer. If you have no family history, the risk of you getting prostate cancer, a relative risk is 1. But if your father has prostate cancer, the risk goes up to 2. You increase your chance, you actually double your chance of getting prostate cancer. If your brother has prostate cancer, you increase it by 3. All right, 3-fold. And if you have 2 relatives in your family, 2 male relatives in your family that has had prostate cancer or greater than 2, you increase it by 5-fold. So family history is very, very important. And those individuals that have family history, we usually encourage them to get screening at a very early age. Now, this is what I just mentioned just now, the relative risk of having prostate cancer. If your father has it, the risk is about 2. If your brother is about 3, and if you have 2 members, it's approximately 5. Now, if you are African descent, that is considered another risk factor, right? And it's very, very common in individuals of African descent, and it's least common in Asian men. Now, it is still unknown exactly, what causes these differences. They do believe that environment has a lot to do with it, and also diet, because some studies have found that Japanese men who have a very low incidence of prostate cancer, when they travel to the United States of America and they start consume the diet that is presented to them, the incidence subsequently increases. So they believe that the diet has a major role to play in prostate cancer, but also the genetics has a major role, and which explains the reason why Africans are at a higher risk of getting prostate cancer. Now, these are some where diet is concerned. There is no factual information where this is concerned. There is a lot of controversy concerning the things that you should or shouldn't eat to prevent prostate cancer. It is suggested that eating more meat and dairy products could increase the risk of prostate cancer, but there's still been a lot of research done in this regard. Lycopene is something that have been spoken about on many occasions in the past. Lycopene is a element that comes from tomatoes, and it was suggested that lycopene can decrease the incidence of prostate cancer. However, subsequently, there have been multiple studies that have been brought forward that have suggested that lycopene does not decrease the incidence of prostate cancer. So I know a lot of men maybe have been actually maybe eating more tomatoes with the hope that it will decrease the incidence, but the studies are suggesting that it does not increase the incidence. But there is a possibility that there is some sort of element that may be there, and maybe more research needs to be done. Now, there is no guarantee way to prevent prostate cancer, but generally the information that I do give patients is don't smoke. And smoking is a risk factor for almost every cancer. Encourage to exercise regularly. One of the things that they suggest is that if you can maintain a healthy heart, you'll increase the chance of maintaining a healthy prostate. So eat a healthy diet, plenty fruits and vegetables, whole grains, lean meat. Now they find out that weight is extremely important where prostate cancer is concerned. Now, obesity does not increase the risk, but what it does, it increases the aggressiveness of prostate cancer when you get prostate cancer. So one of the advice is to maintain a healthy weight. And if you find yourself to be obese, to try your best to try and see if you can decrease the weight. Now, increasing the weight, what it does, it increases your estrogen levels. And your estrogen levels will actually have an impact on your prostate and how your prostate responds to testosterone. All right, so, and that's what weight does. There's an enzyme within the fat cells that convert your testosterone into estrogen. Now, as men get older, do you notice that some men will get breasts? The reason why they get breast formation is because as you get older, your testosterone decreases, but your estrogen level, so your testosterone decreases and your estrogen level increases, and that causes a certain changes in terms of how your prostate responds to testosterone. And the other important thing is get regular prostate screening. That is very, very important. Now, in terms of the symptoms, now prostate cancer can be asymptomatic, and that's actually where we want to diagnose prostate cancer, when the patient has no symptoms. And the only way you're going to diagnose it when the patient doesn't have symptoms is when the patient gets screening, which is doing a PSA, which is a blood test, and doing a digital rectal examination. Now, they may get symptoms. The symptoms include urinary frequency, meaning that they find themselves peeing a lot more often during the day. And then they also can get problems with their pee very often at nights. They may have erection problems. Some patients, that was the first symptoms they had. They have an erectile dysfunction. So when a man over 40 years of age comes to me with an erectile dysfunction, one of the tests that I do is a PSA, because I want to make sure that this gentleman doesn't have prostate cancer, because prostate cancer can cause erectile dysfunction, because the nerves that is responsible for erection runs very close to the prostate. So if there's cancer and the cancer has gone beyond the walls of the prostate, then it can invade the nerves of the prostate. Now, other symptoms that the patient can present with is blood in the urine. They can have urinary incontinence, meaning that they're unable to control their urine. Some may have lost bowel control. Some may complain of pain in the hips, pain in the back, or pain in the chest or legs. Now, usually when they have these sort of symptoms, it means that the cancer has already spread. And prostate cancer commonly spread to the bone first. It either spread to the hips, the pelvic bone, or it spread to the lumbar region. So, and that's the reason why when a patient comes to me, I ask them these symptoms: do they have pain in the hips or pain in the back? So bone pain could be a sign that the cancer spread to the body, and this is known as metastatic disease. And if it's spread to the spine and involving the spine, then the patient may also present as a paraplegic. I had one gentleman who was 52 years of age who presented as a paraplegic. He was already in wheelchair. He started getting weak legs, and then subsequently he lost the movement of his legs. Now, one of the things that we don't do a lot of in the Caribbean is prostate cancer screening. We don't have a formal program set up by the government. What has been happening is that we try to give information like we're doing right now to encourage men to screen. Now, what screening does, you want to try to identify the disease at a stage when treatment can be given that will cure it and help the man live longer. And that's the purpose of screening. And there are two things that we use. We use what we call a DRE. DRE means digital rectal examination. And we also do a PSA. PSA means prostate specific antigen. And this is a blood test that is done. Now, as many of you know by now, in particular the Caribbean, I'm not too sure exactly how it goes in the States or in Britain, but a lot of our Caribbean men are sometimes reluctant to do the digital rectal examination. But as a urologist, I must say that it is very important to do. There's one patient that I diagnosed prostate cancer, it was based on a digital rectal examination. And very interesting enough, this gentleman was of an Indian ethnicity. And prostate cancer is not common in individuals of Indian ethnicity. This guy was also very young. He was 45 years of age. Now, he was having some urinary symptoms. And what I did was I did a digital rectal examination. I said, wow, this prostate feels very abnormal. And it was based on how the prostate felt, because his PSA, even though it was high for his age, it was still within normal range. And it was just only because of how the prostate felt why I ended up doing the digital rectal examination. And it turns out that when we did the biopsy, this gentleman had aggressive prostate cancer. And it had already spread to his lungs, and he died within 4 months. All right, and that was a very, very sad, circumstance. But sometimes when you have aggressive cancer, that aggressive cancer does not produce enough PSA. Sometimes the PSA is low. So that's the reason why we do both the digital rectal examination and the prostatic specific antigen, which is the blood test. Now, this is a picture that's demonstrating how this digital rectal examination is done. The doctor introduces gloved finger, hopefully it's a gloved finger, and this finger is usually lubricated to make it easy for the doctor to get his finger in. Now, there's a technique in which, in how it's supposed to be done to decrease the discomfort that the patient has. And there are a lot of, some of the other doctors, general GPs, are not aware of this technique. So it is uncomfortable, but if it's properly done, the patients most time can tolerate the procedure. Now, PSA is a protein or an enzyme that's produced by the prostate. It's the only organ in the body that produces PSA. So when the PSA is elevated, we know that it's the prostate that's giving problem. There's no other organ that produces PSA. Now, all men produce a small amount of PSA in their blood. And that's why when you look at some of these blood reports, you will see 0 to 4 as a normal value. Now, as the patient ages, this PSA value increases. So we have what we call age-specific PSA. So depending on your age, your PSA should be a certain value. And as a urologist, that's something that we also consider as well. Now, prostate cancer can increase the production of PSA. And that's why we use PSA as a screening agent for prostate cancer. However, I must tell you that there are many other pathologies, many other prostate disorder that can cause the PSA to increase. For example, if your prostate is enlarged, it will cause your PSA, it can cause your PSA to increase. If you have inflammation in your prostate, it can cause your PSA to increase. If you did a procedure recently where a doctor passed a catheter through your penis in your bladder, the PSA can be increased. So these are things that a doctor needs to consider when a patient presents with him with an elevated PSA. Could it be some other reason why the PSA is elevated and not necessarily prostate cancer? Now, generally, the PSA should be below 4. Now, having said that, we have diagnosed prostate cancer in patients with PSA less than 4. And that's the reason why, as a urologist, we look at several factors when we're going to diagnose prostate cancer. Now, when the PSA is above the value, then the doctor generally recommends what we call a prostate biopsy. All right. And if the PSA is very high, the PSA oftentimes can indicate how far gone the disease is. So sometimes a man come with PSA of greater than 100, the chance of it already spread is like over 50%, almost 100%. It has already spread. So the PSA value can give you that information, but it does not diagnose prostate cancer. It tells you that there's a high probability or a possibility that you have prostate cancer. So subsequently, we do what we call a prostate biopsy. Now, there are certain individuals that we encourage to get screening very early. Men of African descent, or if they have a family history of prostate cancer, we encourage them to get prostate cancer screening very early. And early, I would say as early as 45, but if the individual has multiple risk factors, if the person is a man of African descent, if he has a family history, I may encourage him to do this a little earlier, like at age 40. All right. Now, sometimes I encourage men, when men come to me at age 40, even though they may not necessarily have a family history, but they are men of African descent, I will do a PSA, because a PSA, it's supposed to be a certain value, anywhere between, when you're age 40 to 49, your PSA is supposed to be a certain value. If it's above that value, then it increases the probability of that person getting prostate cancer. So this person, I will ask them, you need to be followed a lot more closely. All right. Now, what is a prostate biopsy? It's a simple 10 to 15 minute procedure where a needle is inserted through your rectum or through your buttocks, where we use an ultrasound probe to identify your prostate. Prior to the biopsy, we give a local anesthetic so the patient can tolerate the procedure. After you insert the probe, then we proceed to do 12 samples of tissue, which are taken from different parts of the prostate. And these samples are then sent to the lab, where the pathologist now will look on the specimen under a microscope, and then he'll be able now to tell us whether the patient has prostate cancer or not, but he'll also be able to tell us the aggressiveness of the prostate cancer. So there's a grading system that the pathologist will see if the patient has prostate cancer. And we'd also tell the percentage of the cancer that they would have found. Now, there are risks associated with every procedure. And one of the risks that we expect is, well, not expect, but one of the complications that we try to prevent is infection. At least 1% of patients will get infection. That's 1 out of 100 patients. So prior to the biopsy, we'll give them antibiotics about 15 to 30 minutes prior to the biopsy. And then subsequently, they will continue the biopsy for another 3 or 4 days. And all of this is to prevent infection. But the other problems they could get is blood in the urine, blood in the stool, all right? And they could get blood in their semen. When they have sexual intercourse and they ejaculate, they could actually see blood in their semen. No, but most of these are self-limiting. They will stop on their own, so we don't need to treat them. But if the patient develops infection, we usually tell them, if you have any fever, present yourself to the accident emergency department, where they have to treat you with antibiotics. Now, as I said, with the pathology report, the pathologist will tell you whether you have prostate cancer or not, and will also tell you the aggressiveness of the prostate cancer. Now, when we get all of this information now, then the question is, what is my risk? I have prostate cancer, what is my risk? Now, this information will, you could now decide whether it's low risk, intermediate risk, or high risk. All right, another thing that we say is that the prostate cancer is localized, locally advanced, or metastatic. These are the information that as urologists we want to find out, because depending on whether the patient is low risk or intermediate risk or high risk, it will determine the sort of treatment that we give these patients. Now, localized prostate cancer refers to a tumor which is just limited to the prostate and is not extended to other parts of your body. And if you're going to diagnose prostate cancer, this is where the stage we want to diagnose prostate cancer, where it's localized within the prostate. You have a better chance of it being treated. Now, this is just a picture of a tumor. There's a small tumor in the prostate. Now, this is considered localized prostate cancer. And this would be like a stage 1. This is almost like a stage 2. It's still localized, but it's in both sides of the prostate. Now, this is where it has now gone outside the prostate. You can see where the prostate is. And then this is the cancer, the sign that you see marks tumor, the cancer is spreading right into the seminal vesicle. All right. And that's where you get into a higher stage, a stage 3B prostate cancer. So it's now gone outside the prostate. All right. Again, this is just a breakdown of the different stages. This is a stage 1 where you just have a little bit of cancer. When it spreads, and it spreads a lot more in the prostate itself, but still confined to the prostate, then it's at stage 2. And then if it spread to the seminal vesicle, stage 3. And if it spread beyond, like right here, you see like nodes. All right, when it spread beyond the nodes in the pelvis, it's considered stage 4. Now, when we get the diagnosis of prostate cancer, then we have to consider whether this patient needs imaging or not. And there are several imaging that are available: CT scan, MRI scan, and bone scan. Now, the treatment will depend on a number of factors. It will depend on the extent of the disease and the aggressiveness of the cancer. But what's also important is the person's age at which the cancer was diagnosed and the general health of the patient. So if the patient has a lot of other complications, diabetic, hypertensive, heart failure, we may not do any major intervention because the life expectancy of this patient is short because of all these other problems the patient has. So we wouldn't do anything major. So we take all of these factors in consideration when we're looking to treat patients with prostate cancer. Now, these are the different types of treatment that you have. You have the active surveillance. Now, this is only done in patients who are low risk prostate cancer. And this is where we don't offer surgery, neither do we offer radiation. What we do is we monitor these patients very closely using PSA and repeat prostate biopsy to see if the cancer has progressed. And if it has progressed, then we will go ahead and treat the patient. Now, in a treatment like this, we have to have a very detailed discussion with the patient, and the patient has to make this decision whether they want to proceed with this treatment. I'm seeing something come up on my screen. Proof. Okay, great. So, and then the other thing is we call watchful waiting, and this is another form of treatment where you observe the patient, but in this case, if the person develops any other symptoms, we don't try to cure them, we just try to treat the symptoms. So we usually do this for more elderly patients. But another option is surgery, which is what we call a radical prostatectomy. That's where we remove the prostate and the seminal vesicles. You have radiotherapy, which is a treatment. You have two types, generally the external beam radiation, and then you have what you call the brachytherapy. Now the brachytherapy is where you introduce radioactive seeds in the prostate. External beam, as the name suggests, is external. So it's radiation from outside that is used to radiate the prostate, to treat the prostate cancers. All right, so factors affecting the treatment, usually age, the life expectancy of the patient, or if the patient has other comorbidities like diabetes, hypertension, heart failure. They look at the prostate cancer risk profile, and it also depends on what the patient desires. My thing is not moving. Okay, great. Now, so as I said, the conservative treatment is a type of treatment where the progress of the disease is just closely monitored. And in prostate cancer, this can be done through what we call active surveillance or watchful waiting. All right, now I spoke about all that we do already with active surveillance. I'm not going to go through that again because there are a few more slides to go through. But one of the advantages of the active surveillance is that there is no treated related side effects, because the person is not treated with surgery or radiation, so they don't have the side effects of active surveillance. But the problem or the disadvantage with it is that there's a small risk of cancer spreading outside the prostate, lowering the chance of cure. So we have to let the patient know this. And the patient may also suffer some anxiety from the knowledge of having the prostate cancer. And then the other thing that they have a need for repeat biopsy within 1 to 2 years if they're doing this active surveillance. And some patients may not want to go through that. Now, if the cancer is diagnosed at an early stage, surgery is an option. We remove the entire prostate. Radiation is also an option. And brachytherapy is another type of option. Now, you have another treatment they call cryotherapy, and that's a freezing therapy where you actually put some probes in the prostate where you drop the temperature tremendously, and that will kill the cancer cells. And that's what we call cryotherapy. Now, this is not done in Trinidad, and it tends to be done for patients who have very small focus of cancer within the prostate. But for early stage disease, they have all of these options available to them, and the patient have to ensure that they get all this information from the doctor. So the doctor needs to explain to them the surgery, what the surgery is. They need to explain to them the complication of the surgery. The same thing with the radiotherapy is concerned. The doctor needs to explain to them what the radiotherapy involves, so that, and the complication, so that the patient will now make an informed decision where that is concerned in terms of the treatment. Now, as I already told you what radical prostatectomy is. Who are the candidates for radical prostatectomy? Those that have localized prostate cancer and patients who have locally advanced prostate cancer. So the cancer spread beyond the walls of the prostate, but it has not gone beyond there. It hasn't gone to bones. So those persons still can get a radical prostatectomy, but they also have to get other treatment like radiation and hormonal therapy. So they get like what we call a combination treatment. Now, the surgery can either be done open or laparoscopic. And as you know by now, they also have the robotic as well. And the good thing about surgery is that you can also remove the lymph node, and the lymph node is considered as a policeman of the body. All right. So if the cancer could spread, or it has spread to lymph nodes in the pelvic region, then when you remove the nodes can give you that information whether the cancer has already spread to these nodes. Now, the advantage of doing a radical prostate, as I said before, the lymph nodes can be removed, and this will enable you to better assess the stage of the disease. Now, the removal of the prostate also allows you to have an accurate determination of the cancer. Now, sometimes when you do the biopsy and you look at the biopsy sample under a microscope, and you subsequently look at the prostate that you took out under the microscope, you realize that you will maybe see maybe worse pathology. So removing the prostate will better able for you to diagnose the stage of the cancer a lot better. Now, if the cancer is localized to the prostate, the patient has a higher chance of eliminating the cancer. Now, another good thing, if the patient also have problems with urinating and they also have cancer, then the removing the prostate, that the radical prostate is a very good surgery for that patient versus radiation. Now, the disadvantage is that the person is going to require to be either put to sleep, or they can give them an injection in the spine to deaden the area below. And then also the surgery has complications. Bleeding is a major complication. Infection, not such a major complication, but it's possible. But erectile dysfunction, and that's one of the concerns with men. So there is a great chance of getting erectile dysfunction because, as I said before, the nerves run very close to the prostate. Now, as surgeons, we oftentimes try to do nerve-sparing surgery. Now, that may not always be, possible, because it depends on the stage of where the patient presents. All right, so that's a high possibility. A large percentage of patients get erectile dysfunction. Urinary incontinence, this is where the patient leaks urine. Most patients get it after the surgery, but after about a month or 6 weeks, it subsequently decreased tremendously. By about 3 months, most patients, the incontinence would have resolved. And by about 1 year, 97% would have resolved. Now, radiation, what is radiation? It's a well-established treatment for prostate cancer. It can be used for every stage of the disease, whether it be low risk, intermediate risk, or high risk. And this is where high energy radiation is used to destroy the cancer cells. This can be done by radiation from outside, which we call external beam radiation, or it can be radiation given inside the prostate, and they call that brachytherapy. Brachytherapy is where you introduce radioactive seeds in the prostate, and these radioactive seeds give radiation to the prostate, killing the prostate cancer cells. Now, usually with radiation, you don't need to be put to sleep, and there's no numbing medication that is necessary. But the thing about radiation is that it requires, they normally give this over a 2-month period. So every day, 5 days of the week, Monday to Friday, for 2 months, you have to go and get this radiation. All right. Now, I just explained to you the 2 types: external beam, the brachytherapy. The external beam, as I explained to you, is the patient is placed on a table, and at this point in time, the patient will not, try not to move, because if you move, the radiation may end up radiating some of the organ. Now, while the radiation is given, the radiation oncologist now will leave the room and monitor you from outside, but you'll be able to talk the whole time. And then beams now will come from different directions that we'll use to treat the cancer. The course is usually 8 weeks, 5 days a week, and you receive radiation per day, at least 10 to 20 minutes each day. Prior to the radiation, you get a CT scan, just to map the area that will be radiated, as well as the surrounding tissue. The advantage is that it's administered as an outpatient. The patient doesn't have to be admitted to a hospital to get it. If the patient is unfit for surgery, radiotherapy is a good option. It's a painless procedure that could last for 10 to 15 minutes per session, and no hospitalization is required. Disadvantage, just like the surgery, you could get erectile dysfunction. It may affect the bladder, causing blood in the urine, and it can also cause painful urination. Now, one of the other challenges with radiation is that sometimes 10 to 15 years after the radiation, some patients present with blood in the urine, and sometimes the blood can be so torrential that you have to take the patient to theater and try to see if you can stop the bleeding within the bladder. They also can get bleeding within the rectum, and that again can be a problem. So the patient needs to be aware of all of these situations. Now, this is a picture of a patient, receiving radiation. Now, brachytherapy, as I explained to you, is just putting seeds in the prostate. It specifically goes into the prostate, and it oftentimes doesn't harm the surrounding tissue. All right, you have temporary brachytherapy and permanent brachytherapy. Now, the advantages of brachytherapy is used to treat low-risk disease. The advantage, minimize injury to the bladder and the bowel, because it's very specific. You watch yourself putting that seed inside the prostate. It's a day case procedure. The patient comes in, gets it done, and more oftentimes the patient is able to go home in the evening. Disadvantage that these patients require anesthetic for the procedure to be done. Now, this is a picture showing the prostate, and these are the seeds in the prostate. Sometimes after the procedure, you have to actually put a tube in, because the prostate sometimes gets swollen, and then the patient develops problems with pain. But that swelling eventually settles. Now, locally advanced disease, they may require multiple therapies, such as surgery, radiation, and hormonal therapy. Now, the prostate can spread to other organs or lymph nodes outside the area. This is called what we call metastatic disease. Now, these tumors in other organs or lymph nodes are called metastasis. Your doctor may recommend treating metastatic disease with the hormonal therapy. Now, it is important to realize that the metastatic disease cannot be cured. Instead, your doctor now will try to slow the growth of the tumor and the metastasis. And this will give you a chance to live longer and have fewer symptoms. So, as I said before, the prostate normally spread to the bones, in particular the pelvis, in particular the lower spine. It can also spread to the lung, the liver, and also can spread to the brain, causing confusion. Metastasis in the spine can cause symptoms like severe back pain. Sometimes there's some patients, when they present with fractures, spontaneous fractures, or they may get spinal cord compression, and they come in as a paraplegic. sometimes they can also be asymptomatic. So even though it may be spread already to the bone, you may not have any sort of pain. And in rare cases, lung metastasis or spread to the lung can cause the patient to have persistent cough. I had an uncle who was diagnosed with prostate cancer, and he presented very unusual. He never had any urinary problems. What he had was a cough. And he went to a GP, and the GP treated the cough with antibiotics and cough medicine. But it persisted for 3 weeks. And that's when he called me. At the time, I wasn't a urologist. He called me. So I told him, guess what? We're going to do all the necessary investigations. And we did PSA, which was one of them. When his PSA came back, it came back as over 100. Now, that was when he was in Jamaica. Now, he is an American citizen, so he went up to America. And when they did further tests and started, did imaging and things, they realized that the cancer had spread to his vocal cords. Now, that was very unusual because I've never seen prostate cancer spread to the vocal cords. And it's when they started treating him, then his voice returned and he stopped having the cough. All right, so, gentlemen, I mean, we need to, a lot of times we say men don't like to go to the doctor, but we need to take a lot more responsibility, a lot more care for ourselves. So remember, the body is a temple of God, and we need to try our best to care for it. So this picture is showing the different places where the prostate cancer can spread. All right, and then we use imaging to help us to find this out, where the cancer is spread. Now, the treatment is usually hormonal therapy, and the hormonal therapy involves removing the testicle, removing the tissue within the testicle, and that's where the testosterone comes from. So remove this tissue to reduce the testosterone level and subsequently control the disease, but not cure it. The treatment only slows the growth of the problem and help manage the symptoms. And then also you have to be sent to the oncologist. So the oncologist now will consider whether they should put you on some chemotherapy or some other sort of medication to help treat it. Now, another form of hormonal therapy is injection. There are several injections that you have that will decrease your testosterone level. And the purpose of this is to just control the growth or the progression of the disease. Now, the side effects is that the patient will have hot flushes. A lot of men don't like the whole idea, the lower sex drive and the erectile dysfunction. I've had men come and tell me, hey, doc, I prefer to dead. I don't want, this to happen. And in truth and fact, they will die because if you don't treat it, then it will progress rapidly and they will die a lot sooner than we would like. But some men, they're not going to live without their sex drive, But subsequently, the cancer, when it spread, it actually spread sometimes and damage the nerves, so you don't have no erection and you're still not able to do anything. All right. So the effects of this surgical castration, that's when we remove the tissue within the testicle, is permanent. All right. And some of the symptoms will disappear after treatment. I've treated men using that method who have had back pain. And after the procedure, the back pain left. You have some men who the blood count was low. And then when you treat them, the blood count started climbing back up. They start feel more energetic again, And if you have bone mets, if it spread to the bone, sometimes we give radiation therapy to the bone to see if you can relieve the bone pain and also to prevent fractures. So in conclusion, prostate cancer is a common cancer in Trinidadians, especially men of African ethnicity. It is important to identify the disease before it spread. And so how we do this, we do the digital rectal examination and a prostate-specific antigen, a blood test. The treatment options are available, including surgery, radiation, hormonal therapy, chemotherapy, but it depends on the stage of the disease. Now, at this time, we could choose to ask questions on prostate cancer, but I also have a few slides as well on enlarged prostate. So I'm not too sure exactly what you guys want for me to do. Do you want me to stop here and we'll have a discussion with prostate cancer? Or do we want to talk about the enlarged prostate, which is also a very important thing that affects a lot of men as well?
Hi, good night, Dr. Gooden.
Good night.
We can probably go to the enlarged prostate slides and then we'll go into the question and answer.
Questions after. Okay,
Thank
great,
you.
great.
Thank you very much.
All right, great. Thanks. All right, so we're going to talk about enlarged prostate. The other name for it is benign prostatic hyperplasia. All right, but enlarged prostate, we'll stick to that, but sometimes we refer to as BPH. Now, it's a common condition for men as they age, and it's common for every man, whether it be men of African descent or, but it may be more aggressive in us men or in us Black men. Now, the BPH means that the prostate has grown large. Usually, as I said before, the prostate is the size of a walnut or a golf ball, and it can grow to the size of an orange. And as it enlarges, it squeezes the urethra. The urethra is a tube that passes through the prostate. And as you can see, the image on your right, this is where the prostate is actually enlarged, and it's actually squeezing the urethra, so the person is now unable to pee. Now, the causes of an enlarged prostate. Now, as you get older, the prostate increases, the size of the prostate increases. Now, this is a normal part of aging. It happens to every man. But it's not all men get symptoms, because it depends on how the prostate enlarges. If it enlarges close to where the urine passage is, yes, it will cause obstruction. But sometimes it enlarges closer to the wall of the prostate, which is a little further away from where the urine passes, and it doesn't cause a problem. Now, why this happened? We as doctors, we still don't know why the prostate increased in size. They think it has to do something with the hormonal balance. And one of the things is that the estrogen level increases, and also the receptors on your prostate, the sensitivity of it increases. So it responds a lot more to the testosterone, which is what we call like an androgen. Now, there are also growth factors, it's believed, to also, can cause the prostate to increase in size, and genetics may play a role. Now, is BPH a type of cancer? No, it's not a type of cancer. It is completely benign, and it also is not a precursor of prostate cancer. So when you hear that you have enlarged prostate, don't worry yourself that it's going to cause cancer, but it's something that still needs to be looked at closely and be treated. Prostate cancer can also cause similar symptoms as BPH. So when patient comes to us, they have urinary problems, we also assess them for prostate cancer, and we also assess them for enlarged prostate, because both of them can coexist, and that's important to know. So BPH, the B is benign, and it means non-cancerous. The prostatic means it's related to the prostate, and the hyperplasia means that they're increased in the number of cells. We commonly call it, from a layman standpoint, enlarged prostate. And BPH means the prostate gland has grown larger than normal. And sometimes, and a lot of patients, they can get urinary problems where they're unable to either pass their urine, or they may have problems like frequency or straining. Now, BPH, enlarged prostate, affects 50% of men over 50. All right, between 50 and 61, 40 to 50% of men are affected. And by the time you reach 80% of men are affected. Now, obesity, higher body mass index, and lack of exercise could increase the risk of BPH. And obesity seems to be a big issue. One of the factors, it's a factor in prostate cancer. It also is an important factor in BPH. Now, some of the symptoms that you get: hesitancy. Hesitancy means that you want to urinate, but when you go to the bathroom, it takes a while to come. Then straining to pass the urine. You may find yourself having to force a little more to get the urine out. Then when the urine comes out, then you realize the stream is now weak. normally when you pee, you realize, when you're a young boy and you pee, it's going very far. But now you're peeing and the pee dropping on your shoes. Now that's a concern. Or sometimes while you're peeing, the urination, it stop and go. That is a sign that you could have enlarged prostate. The other symptoms you could get is urgency, where you have to rush to the bathroom. Another problem that happens a lot with men as they get older, they pee very often at night. You call that nocturia, where they pee often. They get up at least one time for the night to urinate. That's nocturia. But it doesn't bother them until they have to get up about 2 or 3 times to urinate. It affects their sleep. And when it affects their sleep, it affects their cardiovascular status. So they put their risk at getting high blood pressure. They put themselves at risk of getting strokes and stuff, because they're not getting proper sleep at nights, because they have to get up ever so often to pee. They can also get pee very often during the day, and you call that urinary frequency. Now, when the patient comes to us, we ask them all of these questions, and we have a little questionnaire that will actually assess them to see if they are mild, moderate, or severe. Then we do what we call a physical examination. We examine the abdomen, what we're looking for. Sometimes when the men come, the urine is backed up, and so they have a full abdomen, and they don't even realize it. The other thing that we examine is we examine their neurological status, because sometimes the problems that they're having with their urine is because they have a neurological problem. There's something wrong with the nerves. Maybe they had a history of trauma. Diabetes can damage the nerves. So that also could affect, how you pass your urine. We also examine the penis, because sometimes some men, the foreskin, they haven't done circumcision. So sometimes the foreskin is tight, and that's what causes them to have problem, and not necessarily the prostate. So as a urologist, I don't assume when a man comes to me with urinary problems that is a prostate. It could be medical problems that causing them to pee regularly, like diabetes, for example. It could be the medication that they're on. Also, it could be a behavioral problem. Maybe they're drinking too much caffeine, so they pee very often at night. Maybe this is one of these persons who love sports. So they're in the living room watching sports at night, and they have a crate of stag, by them side, or some beer by them side, and they drink that. And guess what? When they're ready to go to their bed, every minute they're getting up and pee, because alcohol will make you pee. So as a urologist now, we assess all of that. We look at the possible problems that they could have that could affect their urination, and not just assume that it's prostate. All right, yes, we're going to think about prostate, but we also need to think about other problems. And then the other thing that we do is we examine the prostate, and when we examine it, we get an idea of the size, but we also get an idea of how the prostate feels. And that may give you a clue that this patient may also have prostate cancer. Some other tests that we do after we examine the patient, we collect some urine. We could test the urine to see if there's any infection in the urine or there's any blood in the urine. These are things that could cause urinary symptoms. Now, we also do what we call post-void residual volume. What that is, we do it using an ultrasound. So we ask the patient to drink fluids, and then we measure the amount of fluid in the bladder using the ultrasound. Then we ask the patient to pee, and then we measure how much urine is left behind. Now, the urine that is left behind should, for most part, be less than 100. Normally, it's supposed to be nil, but as you get older, we give and take. You're going to have some urine left behind. But if it's over 100, it's considered significant, and it may mean that the prostate now is so large, you can't pee well and not flowing well, so you retain a lot of urine after peeing still. And again, some patients are not aware of this. I've seen a lot of men who say they are comfortable, but when you do the test, they realize that they have problems with urine. And if we're not too sure what the problem is, we have this other test we call a urodynamic pressure flow study. And this is a more specialized test to help us to find out, what the problem could be. Then we also do the kidney function, because when the prostate is enlarged, the prostate can damage the bladder, and then the urine now can reflux and go back up into the kidney, so the kidney can get enlarged, and sometimes it can affect the function of the kidney. So when these patients come, we do the PSA just to see if they have prostate cancer, and we do a kidney function to see if they have enlarged prostate, is it causing damage to the kidney already? Because this is another indication for us to treat this patient surgically. And ultrasound, as I said before, is something that we do where we look at the kidney, we look and see how well the patient emptying the bladder, and we also look at the prostate size. And then now we go on to treatment. Now, if the patient only have mild symptoms, we can observe the patient. All right, but if the patient has moderate to severe symptoms, then we have to consider drugs, and then the next thing will be surgery. And this is if the patient has complications of BPH, then we highly recommend surgery. So when we're going to treat patients by observing them, and these are patients that usually have mild symptoms, it means that every year we need to examine these patients, want to see if the symptoms have gotten worse. These patients, they're not subjected to surgery, neither are they subjected to receiving drugs. It's just a matter of lifestyle modification, looking at their diet, the type of fluid that they drink, the amount of fluid that they drink, the medication they use, and the exercise patterns. Now, drugs. Now, there are about 4 sets of drugs that we use to treat prostate, enlarged prostate. One of them is an alpha blocker. We call it, I call it Usain Bolt. So when I'm talking to the patient, I said this works like a Usain Bolt, meaning that the more, as soon as you take it, it starts acting almost right away. All right, but what it does, it relaxes the muscle within the prostate, and so it makes it easier for the patient to pee. Now, there's another type of drug, which you call, well, it's just called 5-alpha reductase inhibitor. All right, I'm just telling you the name, you may not understand what I'm saying, but what it does is decreases the size of the prostate. And then sometimes, so it depends, if the person's prostate size is above a certain value, that's when we put them on this particular medication. Now, oftentimes when we treat patients with enlarged prostate, we combine both these medications. The alpha blocker, which is the one that acts quickly like a Usain Bolt, or the 5-alpha reductase inhibitor that acts like a Kenyan runner, like a long distance runner, because this particular medication, you have to be on it for 6 months before it decreases the prostate size by 25%. Now, the alpha blocker, as I said, is intended for men who already have moderate to severe symptoms, and it provides immediate relief. But some of the problems that it can get is that it can drop the blood pressure, it can cause dizziness, it can cause fatigue, nasal congestion, and it can also cause abnormal ejaculation. Now, the more recent alpha blockers, they don't drop the blood pressure like the ones of old, and they don't cause much of a dizziness like the ones of old. So that's a good thing. But one of the problems with it is what we call retrograde ejaculation. What happens is that when you ejaculate, instead the ejaculate comes out, it goes back into the bladder. But what happened? You pee out. So after you pee, you find your pee looking cloudy, and you wonder what that is. But yes, it could cause that. All right. Somebody's switching my stuff. All right, cool. So 5-alpha reductase inhibitor. All right, is intended for men with certain size prostate. So the prostate has to be a certain size. And what it does by reducing the size, it reduces the risk for the need for surgery. All right, so reduces that risk. But the side effects, potential side effects, is erectile dysfunction, impotence, lower sex drive, but it's only a small percentage of men that will get this. And it lowers the PSA by 50%. That's very important because sometimes some doctors, GPs, will put men on this medication and the PSA drops and the men are happy thinking that, oh, my PSA is good, but the doctor did not treat the man properly, because when the PSA is high, what he should have done is do a prostate biopsy to see if this patient has prostate cancer. But some GPs will put them on it, and when the PSA drops, the patient is happy, he's the best doctor in the world. All right, so don't be fooled. All right? And that's why information is so critical. All right, now surgery is another treatment option, but we usually do surgery when you have problems like these: recurrent urinary tract infection. If the person have a bladder stone, enlarged prostate can cause bladder stone. It can cause the patient to go in urinary retention where they're not able to pass the urine. And no matter what we do, we still have to keep a tube. Those persons need surgery. It can damage the kidney. And then sometimes when you give them the medication, the medication may fail, or sometimes the patient is unwilling to use medication and they prefer to go straight to surgery. And one other complication of enlarged prostate is blood in the urine. Patients can get frank blood in the urine, and it's because of the enlarged prostate. And if that happens repeatedly, yes, the patient needs to get surgery. Now, these are the different types of surgical therapy that's available. One of them is, these are all of them, but the most common ones are transurethral resection of the prostate. And that's where we pass an instrument through the penis and actually scrape the prostate to create a channel so the patient, a bigger channel so the patient can pee. This one called simple prostatectomy. If the patient has a very big prostate, we have to cut them and take the prostate out. All right. Now, one of the latest invention is laser enucleation. And this is used particularly for big prostates. The good thing about laser enucleation is that the patient loses less blood. And if the patient is on any tablet that will thin their blood, making it easy for them to bleed, the laser enucleation is a good option for such patient. Resume is a new method that's been introduced. It's not available in Trinidad as yet, but the resume is actually where they use steam, and the steam gets converted to water vapor, and it gives off energy that actually destroys some of these cells, so the prostate gets smaller as a result. All right. So the transurethral resection, we do it for prostate size up to about 100. The mortality rate is low. The results are excellent, and oftentimes these patients don't need retreatment. They do very well. But one thing you need to understand is that the prostate can regrow. So even but it usually happens 10 to 15 years after. The disadvantage of this procedure is that the patient may get retrograde ejaculation. So the ejaculation goes back into the bladder instead of comes out the penis. At the time you're doing the procedure, yes, you get minimal bleeding. Now, most of the patients that I've done, if not almost 100% of the patient, they don't need any blood transfusion. So the bleeding usually is minimal. And oftentimes they are hospitalized overnight, or sometimes if you do the procedure very early in the morning, they can, go home late in the evening. Laser is, as I said, a new clinic on the block here in Trinidad. There are people here who are doing laser, but it's an alternative to the open prostatectomy where you have the very big prostates. But the open prostatectomy is still an option, is something that is still being done to remove these prostates. However, laser is an option if patients choose to go down that road. Now, the endoscopic surgery with laser is considered to be safer when compared to open surgery. And you don't need to stop any of the medications like when they use to thin the blood, especially patients who are heart patients. You can safely do laser with patients who are on these medications. They get lesser blood loss with this laser therapy, and they have fewer complications. Now, they also considered to have less pain after the operation as opposed to open surgery, and they are discharged early. When we do open surgery, a lot of times patients may stay for like 1 day or 2 days, depending. So it's not that bad, eh? So, I mean, they talk a lot about the laser, but if the person knows how to do the open procedure properly, they're able to still get very good results with the open procedure. But with the laser, I think one of the benefits of the laser as well is that the patients are able to go back to work very early as opposed to open surgery. And with open surgery, the patient may have to wait for about 2 weeks to 4 weeks to go back to work, depending on the type of work they do. But having said that, laser patients sometimes may have to wait 2 weeks as well, because they may still have a little bleeding sometimes. But generally, the patients are able to go a little earlier with the laser surgery. Now, one thing I need to mention, a lot of men come to me having been on salpalmetto. A lot of men take that. They're happy, they're taking something to help the prostate. But according to the American Urological Association, there is no dietary supplement or other non-conventional therapy that is recommended for the management of patients with urinary problems secondary to enlarged prostate. Salpalmetto has been studied, and they have had proper clinical trials, and it has not proven to be of benefit. It has been, the results is just as same as placebo. All right, so I tell them when they come to me, guess what? I mean, you tell me taking sulfur-metal. I said to him, well, so as if you have money to waste, and if you do, instead of spending on sulfur-metal, why not just give me? Because the truth and the fact, they have not proven that sulfur-metal works. Now, I know they have other things on the market. I know about the prostagenics. I don't know much about it. A lot of popular men have been coming on television to say that it works, it improves symptoms, but I still don't know much about it, so I can't comment on it to say it's a good option. So in conclusion, enlarged prostate is a common problem in men. It's not cancerous, it does not cause cancer, and it can coexist with cancer. The symptoms that it have is similar to the symptoms of prostate cancer. If not recognized early and treated, it can lead to life-threatening problems. I've seen patients died from enlarged prostate because of kidney failure or because of bad infection. There are many treatments that are available, and I suggest to men, if you're having urinary problems, always consult with your urologist to determine your best treatment option. Thanks very much. I have this very quote that I like so much. Knowing is not enough. We must apply. Willing is not enough. We must do. Thanks.
Thank you very much, Doctor, for that insightful discourse on the prostate. Now, people online, we want to ask the doctor some questions. I'll pull one off that I saw. Doctor, in terms of the digital test in versus the ultrasound, what is the merits and demerits of both procedures? Right. So in terms of doing prostate cancer screening, the PSA, all right, and the digital rectal examination is what we use. The ultrasound does not diagnose prostate cancer. All right, we use the ultrasound to help us determine the size of the prostate, and we also use it to guide the prostate biopsy that we do. But ultrasound, I see a lot of people do it. They do an ultrasound, and they may see certain changes, and they say, "Oh, this person has prostate cancer." No, it's not until when you do the prostate biopsy, we take pieces of tissues sent to the pathologist before we can say the patient has prostate cancer. Thank you very much, Doc.
Thanks for the information.
Excellent. We'll take some questions now, but we wanted to indicate you want to ask a question by going to the reaction button and just raise your hand to indicate if you want to ask a question. So we'll ask the doctor some questions now. You can feel free to indicate when you're ready. Richard, and you all keep notes so that we can identify persons willing to ask a question. All right.
Doc, could you close off your screen, please?
Close it off.
Could you stop sharing?
Let me see how I do this now. Let's see. So let me see how I do this now. With the sharing and just
If you hover at the top of the screen, a menu will appear.
Yeah, but come and show me how to do this thing here.
Hover your mouse at the top of the screen.
The top of the screen, I see we have
a menu should appear. Right, click and select stop sharing.
And select, where is that now?
It will be at the top of the screen as well.
It's a
I seen Dr. Gooden's screen.
Click on that. Right, that's a stop share. Sorry, right. I'm seeing it now. Yeah, thanks. Mm-hmm.
Right, so let's go with Fire Tablet. Fire Tablet, go. You can go ahead. The person indicating their hands up, Fire Tablet. Please go ahead. Or we'll go to the other person. Okay, let's go to Arnhem Johnson.
Good night, doctor, and good night, everyone.
Good night.
Thank you so much for the information. My question is, if you are a high-risk person, meaning that your father has prostate, you have African descent, what would you recommend my diet be, and what I should stay away from?
Right. No, as I said in the presentation, there is nothing that has been identified where your diet is concerned that you could do to prevent prostate cancer. Now, as I said before, they have spoke about lycopene in the past to say that lycopene that you will get in your tomatoes and other stuff, that it could decrease the incidence of prostate cancer. However, recent studies have found that it actually, not the case. They have looked at vitamin E and they have looked at selenium, and they realized that this has not actually decreased the risk of prostate cancer. As a matter of fact, in some cases, some patients actually develop more aggressive cancer taking the selenium and the vitamin E. So generally, what they have suggested is that the same advice that we give individuals to protect the heart is the same advice we give individuals to protect the prostate. And so they have a thing now where they say a healthy heart equals to a healthy prostate. So generally, regular exercise, if you smoke, you stop smoking, try to eat a lot of fruits and vegetables and exercise regularly. But what is very, very important, which they have realized in a lot of studies where it relates to prostate cancer, where it relates to enlarged prostate, that if you have a lot of weight, you actually increases your risk of getting aggressive prostate cancer, and it also increases your risk of getting enlarged prostate that cause urinary symptoms. So, keep a healthy weight. If you're overweight, try to see if you could get that down. Regular exercise, eat a lot of more fruits and vegetables, all right? And essentially that, and keep a positive mind.
Yeah. Doc, I could ask you a question, right?
Yeah, man, go ahead.
All right. I just did ultrasound, right? Ultrasound on the prostate, right?
Right.
And I have the results in front of me here. You see,
right.
The prostate gland measured 30 cc.
Right.
On trans-abnormal imaging.
Abdominal.
Right, abdominal. Prostate dimension 3.8 cm. 1 IS, it looking like capital IS or LS. Multiply 4.5 centimeters. TS, right? Multiply 3.4 centimeters AP. What does that mean?
Yeah, that's just the size, the different size of the prostate. So they gave you the volume, but you need those values that you just gave me, is the values that they use just now to calculate the volume of the prostate, which is 30. So as urologists, what we look at is the volume, the final figure, which is the 30, all right?
Right.
Those figures that you got was just different dimensions of the same prostate.
All right, because he also said for a kidney test, a kidney ultrasound and prostate ultrasound. Does that work together?
Yeah, so at the same time, when you're doing the ultrasound, you could look at the kidneys as well. Because as I said before, if depending on your symptoms, I don't know what sort of symptoms you're presented with, but depending
no, actually, I had an abdominal hernia, and when I went for surgery, they told me that I had an irregular heartbeat.
Right.
So he's treated me for the irregular heartbeat, a month supply of tablets.
Right.
And he sent me for those two things. So does that coincide?
No, well, actually, I'm not too sure why he sent you for them, because remember, the doctor would have had all your information in terms of your history and stuff.
He's a cardiologist. He's a cardiologist.
Right, exactly. He's not a urologist. So I don't know. I'm not too sure exactly why he sent you for those. All right. I mean, as a cardiologist, he wants to make sure that your kidney is functioning well, because if your kidney doesn't function well, it can also affect your heart and vice versa. All right.
Yeah,
so go ahead.
Yeah, but I have no problem urinating. I urinate twice per night.
Right, right.
You know, and well, I'm 68 years of age. You know, I'm not sexually active. You know, as before. You know.
Right,
you know,
right,
right.
right.
You know, I can still bowl a ball. You know, but you know.
You can still bowl a ball. You can.
At 68. At 68. At 68.
All right, great, man. Great. Not many people can do that.
All right, right. All right, Doc. Thanks a million. But you are in a general hospital.
Huh?
You work in a general hospital, or you have your private?
I work in Prostate General Hospital, but I also work in several private institutions in Trinidad.
All right, Doc. I'll get in contact with you.
Yeah, man. No problem. No problem.
It was very informative, and God bless you.
Yeah, man. Thanks very much.
Okay, so now we will go to fire tablet. Fire tablet, go ahead.
Lana, you heard me?
Fire tablet. I'm seeing fire tablet on top of my screen. All right, so let's go to Mark Shind.
Mark Shind. All right, I saw somebody was asking if I have a private practice. Yes, I do. In South, I have a private practice at Acropolis Medical, that's on Circular Road. I have in North, I have a practice at in St. Augustine at Integrated Surgical. And I also have a private practice with the Seventh Adventist Community Hospital, and another private practice, Newtown Medical, which is a new one on Woodruff Street. That's where the American Embassy is. Newtown Medical is the name.
Yeah,
what you can do if you feel my number can be issued to anyone if they wish. My number is 465-1575. 465-1575. Now you could feel free to call me, and then I'll be able to give you the other information in terms of the different private practice.
Could you repeat the number again for me, please?
465-1575.
All right, thanks.
Okay,
right,
you're welcome. Welcome.
So let's go to Garnet St. Louis. Go ahead, Garnet.
Yes, good night, everyone.
Good night.
Thanks, Doctor, for the timely information.
Most
right,
welcome.
My question is, can someone has a very low, meaning under 1, less than 1, point something, right?
Point something.
Still, well, 0 point, less than 1.
Yeah, less than 1, but what, 0.1, 0.
Yeah, 0.4, 0.3, less than 1. Because the margin is 1 to 4. And it has a reading of less than 1. Can that person still be diagnosed with cancer, prostate cancer? Is it possible? Is it possible?
All right, so let me say this, right? So even though they have 0 to 4 on the lab form as being normal, 0 to 4 is not actually a normal value per se. What we use the PSA to do, the PSA helps us to know what risk or the probability that the patient has of getting prostate cancer. So we have seen patients with PSA between 0 to 4 that has had diagnosed with prostate cancer. Some of them actually have had aggressive prostate cancer, even though it was within normal range. So one of the things that we do when we see a patient, we ask the patient to do their PSA, depending on their risk, to do their PSA like once per year. And what we do, we watch how fast the PSA rises. So for example, if you come to me and your PSA was 1, for example, and in 6 months' time, 8 months' time, that PSA jumps to 2.5. Now that now becomes very, very critical to me, because then I'm gonna have to now watch this patient a lot more closely. The other thing that I want to point out, that if you do your PSA at different labs, you will get different results, because they have different reagents, all right? Different reagents to test at different labs. So you may do your PSA at one lab, it was 2.5, and you do it at another lab and it comes as 3, and you start worrying yourself. So I tell patients, stick to one lab, all right? Stick to one lab when you're doing your PSA. And yes, it's very rare for somebody of a PSA that low to have prostate cancer. And I have actually never seen somebody with a PSA less than 1 with prostate cancer. But there have been studies that have shown that there have been people with low PSA that can actually get prostate cancer, right?
Let's go to another person.
Thank you.
You're welcome.
Mark Shindian. Mark Shindian.
Yes, good night. Dr. Gooden.
Yes, sir.
Right. I'd like to find out how often should a 40-year-old, or how often is it recommended that a 40-year-old be tested for prostate?
A 40-year-old?
Yeah.
Right. So what I do recommend, when we look at the guidelines suggest that it's okay for a 40-year-old to do a PSA. And then what we do, we look at the value of the PSA. Now, your PSA should be less than 0.7. So if I do your PSA as a 40-year-old and your PSA come back as 1.5, it concerns me. So what I do, I monitor that patient a little bit more regularly to see if this PSA is going up. Now remember I told you, there are other factors that can also affect a person's PSA to go. If the person have a urinary tract infection, could be that the reason why the PSA goes up. So we look at all these other factors. The other thing that is very, very critical, and as I speak, these things coming back in my spirit. When you do a PSA, ensure that you don't have any sexual intercourse within 3 days of doing your PSA, or don't do any form of masturbation within 3 days of doing your PSA, because those things can cause your PSA to increase. If you have a bicycle and you went on a marathon ride, because you're sitting on a saddle and the saddle is pushing up against where your prostate is, then your PSA could also elevate, all right? So some people who are very rich and they can buy themselves a horse. If you're doing horseback riding, that also can cause your PSA to go up as well. So these are other things that we need to keep in consideration. But yes, at age 40, if you do a PSA, it should be less than 0.7. If it's a higher than 0.7, I would like to maybe monitor this patient a little closely, but it doesn't mean that they have prostate cancer. It just means that the probability of getting it in the future has increased. Now, if you're anywhere between 40 to 49, your PSA should be 2.5. If it's above 2.5, then that is concerning, and sometimes I will recommend the patient doing a prostate biopsy. However, I should also tell you, they have what you call a multiparametric MRI, And this is a special MRI that will look at your prostate, and it can tell you that there is a little focus somewhere there in your prostate that suggests that you have a high risk of having prostate cancer in that location. So sometimes in patients, we may do the MRI before. The MRI must give us an idea where the cancer may be, so that when we do a prostate biopsy, we could concentrate our prostate biopsy in this particular area. All right. Now, I say where somebody asked a question just now, and the question was about the at age 60, what should be the normal PSA. So between 40 to 49, your PSA should be 2.5. Between 50 and 59, it should be 3.5. Between 60 and 69, it should be 4.5. And between 70 to 79, the upper limit is considered 6.5. But at that stage, between 70 to 80, sometimes we are very reluctant to do prostate cancer screening for these patients. But if the patient has a very good health and they have a long life expectancy at that age, then yes, we'll do PSA screening for them at that age.
Doc, we have a question from on YouTube. Don Leon is saying there's a new treatment for BHP called Resume. do you do this treatment or do you conduct this treatment?
No. So right now in Trinidad, nobody does resume right now in Trinidad. No, you see, with this new treatment, it's also very good to get adequate information. I am not actually impressed with the treatment, but it's a good option, especially for people who can't undergo any major surgery, because you actually can do this procedure in your office. It's essentially where you introduce a instrument through the penis, and steam is given off, and this steam is introduced into the prostate that actually kills the prostate cells. I'm getting a feedback there, guys. Right. So this steam will actually kill the prostate cells. However, the patient is going to require to have a tube put in, a catheter, which may last for 3 to 5 days. And then subsequently, they may have to wait 6 weeks for this prostatic tissue cells to die so that the cell size decreases. It's a good option, as I said, for individuals who are not able to undergo any major surgery because of other cardiac, problems with their heart or something like that. It's a good option. It's an office procedure. It's not yet available in Trinidad. We have been introduced to it. However, it's going to be an expensive procedure because the price of the whole setup is expensive. So when you put all the prices together, yes, it's going to be expensive, but not available as yet. So we'll see what happens in the future.
Thank you, Doc. We're going for fire tablet for the third time. Fire tablet, go ahead.
You need to unmute fire tablet, so maybe you're not realizing that you're not unmuting.
Okay, well, let's go to Mohammed then. Mohammed, go ahead.
Okay, go ahead.
Good night, Doc.
Yeah, good night.
Good night. I had a ultrasound done February last year. The results were by the whole gland volume is 59.4 ml.
Right.
Prostate capsule is normal.
Right.
Seminal vesicles are normal.
Yeah.
The periprostatic fat is normal.
Right.
Right, but I have an enlarged prostate.
Right.
And April this year, I did a PSA, which was 2.8.
Right.
I am 70 years old.
Okay, excellent.
How do I go about treating this enlarged prostate?
Right. So your PSA is very, very much normal. It means that your probability of having prostate cancer or getting in the future is extremely low because of your PSA being 2.8 at that age. All right. So that's very, very good. In terms of the enlarged prostate, what a lot of people need to understand, and a lot of people do this, a lot of doctors do this. What they do, they order ultrasound. And then the ultrasound says that your prostate is big. And then what happens? The patient starts fret and get anxious. No, not because the ultrasound says that your prostate is big. What we assess as urologists is your symptoms, all right? So as I explain to patients sometimes, when your prostate is enlarged, it can enlarge on the periphery. So the tube that passes to your prostate is actually in the center. So if it's not compressing the tube, it's not causing any problem. So having an enlarged prostate based on an ultrasound does not mean that we treat the patient, all right? Or that the patient needs treatment. We look at the symptoms that the patient is experiencing, and it's the symptoms that determine if we treat the patient.
So could I take any tablets to reduce that?
Right. So that is something that you have to be extremely careful about, because there is a tablet that can be used to decrease the size of the prostate. It decreases by 25%. So at a size of 60, you may be able to get 10 to 15 grams off. However, it has side effects. So if a patient doesn't have symptoms, I would not put that medication for that patient to decrease the size of the prostate, because then the patient doesn't have the symptoms, but then I'm giving him something that's going to cause side effects, right? But again, the patient can decide what they want to do, but I'm like to be very open and very frank with patients about these things.
In urinating, sometimes, you know, it takes a little bit to come, but then sometimes I have to squeeze the penis, let back up a little bit, and then it flows. Now, when it flows out, if I sit on the toilet, more comes out again.
Right. So it could mean that, yes, you may have a problem because your urine shouldn't flow like that. All right. It should be able to flow one time and finish.
Finish.
Yeah.
But when I finish urinating standing, there's no urgency, there's no need, but I will still sit to see if any more wants to come out. Right.
Yeah. Now that you need to get checked up. There's another test that you could do just to test the flow. The flow of the urine, we call it uroflowmetry, and that may give us some more information. The other thing that I always tell patients, apart from the prostate being enlarged, one of the other things that happens to patients as they get older, or to men as they get older, is that the bladder also gets weak. So sometimes what we do, we actually put them on the Flomax, which is a tablet that operates like Usain Bolt very quickly, relaxes the prostate. And so it makes it easier now for the bladder muscle to get out that urine, because now the prostate is a little bit more relaxed. So sometimes with the older patients, I will put them on the Flomax for that reason.
Yeah, but sometimes you take Flomax, but it affects. Sometimes I was taking Flomax and I was getting dizzy, like it was affecting my
right.
How you call it?
Your blood pressure.
Blood pressure.
Yeah. So there's a small percentage of people that will get dizziness, and as a result, I will maybe stop it if I maybe try another medication. There's another one they call terazosin.
Apoterazosin.
Right.
I'm using that right now.
Right. Terazosin, can cause dizziness more than the Flomax. However, the terazosin, we can titrate the terazosin. So we start at a smaller dose and see how the patient responds.
How much, about 2 mg?
Yeah, 2, and then if the patient is doing well with that, we keep it at that. If the patient doesn't have the dizziness, but the urinary problems is not improving, then we increase the dosage.
All right, Doc, another question as we go forward. We want to ask Osei Mohomba. Can you come on, Osei? Osei, are you there?
Hello. Yeah. I'm here. Hello. Dr. Gooden.
Yes.
Yeah. The issue of sexual frequency, how does it reduce the possibility of prostate cancer?
All right. No, so yeah. Right. So there was a study that was done recently. I want to say recently, maybe 2-3 years ago, where they were suggesting that if a person have frequent ejaculation, in other words, frequent sexual intercourse or masturbation, that could actually decrease the risk of prostate cancer. Now I know a lot of men get excited when they hear that, because then they say good reasons for my wife to have sex with me, or whatever. But I mean, that was said, but it's something that still needs to be looked into. I couldn't explain that study why that happened, and I maybe need to look a little bit more detail in that particular study. But there is no guarantee that that's the case.
Words?
Let's take Earl Jones, and we want to wrap up by 9:30. So we'll take 2 more questions.
So somebody asked if the
my hand's still up.
1 minute. I saw somebody ask if digital rectal examination is the prostate biopsy. No. Digital rectal examination is just me, the doctor putting his finger his glove lubricated finger in the back passage just to feel the prostate. But with the prostate biopsy, you use an ultrasound probe to identify the prostate and then take several tissues from the prostate to send for testing.
Can I ask my question?
Yeah, go ahead.
Yes. Right, okay. So, Dr. Gooden, what would cause an increase of a PSA rating that was maintained at 1.01 for a period of 2 years? And let's say it increased up to like about 3.2 as the case might be. What would cause that? So for 2 years, you have maintained 1.01 and then it started to climb.
Yeah, right. So as again, if a patient comes to me with these figures, I mean, I will find out questions like, did you have sexual intercourse within 3 days of doing this PSA? Did you masturbated within 3 days of doing this PSA? You know, did they have a recent procedure like they had put a catheter in the bladder? Because these things can also cause the PSA to go up. Now, that's a big jump from 1 to 3. That's a very big jump. So that is very suspicious. All right. But what I do in that case usually is to repeat the PSA. And if the PSA remains that high, then I have a discussion with the patient about the possibility of doing a prostate biopsy. Because as a urologist, one of the things that we do, we look on what we call a PSA velocity. That means how fast the PSA increases. And that is something that we also look at to determine whether we should go ahead and biopsy this patient.
Okay, Jones, go ahead.
Yes, good night, Doc. Very, very good. I enjoy your presentation. Great. My question is that you say to exercise, is there any special exercise recommended? And another question is that what about bicycle riding? Is that not good for men?
No, all right. So bicycle riding is fine. It's a good form of exercise, a good form of cardiovascular exercise. So our aerobic exercise, like swimming, running, and all. So I'm not saying that you can't do bicycle riding, all right? But what I'm saying is that you have to be aware of the fact that riding a bicycle, because you're on a saddle and you're riding for very long, you could put yourself, when you do your PSA, the PSA may be increased, but it may not be due to the cancer, but you may think that, oh my God, I have a problem. So that's important for men to know, because I've had men with stationary bikes at home, which they use as exercise, and they went and do a PSA, and guess what? Their PSA was high. And then, you know, by having a conversation with them, we realized, oh, you use a stationary bicycle at home? I said, guess what? This is what I want you to do for me. I want you to not ride a stationary bicycle for a few weeks, and then let us repeat this PSA and see if this PSA will come down. But in terms of exercise, aerobic exercise is always good, but resistant exercise is very good. And they talk about doing very vigorous exercise as well, which can be very, very healthy for your cardiovascular system. And the frequency in which you exercise is also important. I know the Cardiovascular Society in the States, they suggest at least 4 days for half an hour. But as much as you can do, but before you do any exercise, just ensure that you consult your physician, just in case if you have any heart issue, don't want to go on the road and you get a heart failure while doing the exercise, all right? You have to make sure that your heart is in good working condition before you undergo very stressful exercises.
Doc?
Yes, sir.
Could I ask you a question here?
Yes, sir. That's what I'm here for, sir.
Okay. When I get up in the morning and to pass urine, I go over the bowl. It takes a little time before it comes down, and when it do come down, I flow plenty, very slow, just running out.
Right.
Is there something I can take to bring on that urine more?
Right. So what I advise for you to do is to check your doctor. I mean, better yet, a urologist. There's enough urologists in Trinidad that you could contact. because we need to, investigate. We need to ask certain more questions, to see what other problems that you're having, and then we need to do some investigation to see how well you empty the bladder, to see how good the flow rate is, and to also look at the size of the prostate and your post-void residual, how much urine is left behind after urinate, and that will determine our treatment. And you have medications available that can help it, because obviously what you're describing is that you could possibly have an enlarged prostate. But one thing I just want to tell individuals, please, there are other things that could cause you to have problems with your urine. Things like what we call a urethral stricture. Urethral stricture is a narrowing in your urethra. Your urethra is a tube where your urine passes. And some individuals, especially young men, can present like that because if you have sexual transmitted disease, it could damage your urethra and subsequently present with a stricture formation. Or maybe you had some procedure done before, so it could be stricture. It don't necessarily have to be a prostate. And that's why it's important for you to visit a specialist to see what the real problem is. They need to investigate you properly for that and then subsequently treat you depending on what they believe is the problem.
Okay. Just before you end, host, I want to say to Dr. Gooden that I privately inbox him if he can check his check for a message for me, please. Okay.
Okay. All right, cool, no problem.
Dr. Gooden, could you take one more question? There's one last one.
I
would love to have answer question.
You guys could go ahead, I mean,
okay.
I've made my time available. I know that you would have a lot of people, so I made my time available to try my best to inform, as much men as possible. So go ahead.
Okay, so I had the DRE test about 10 years ago.
Right.
I was told that I need to get it tested again in 10 years' time when I got it, right? And so last year I got the PSA test. I changed doctors and I got the PSA test, but I'm wondering whether I should also go ahead to have the DRE test this year because it becomes due this year. Should I also go ahead and get the DRE test?
Right, so, well, there is no specific time regime where an individual can do, should do a DRE. But you routinely will tell a patient that a PSA generally could be done once per year. However, it depends on the individual risk because if the patient did a PSA and the PSA was very low, we may not ask them to do it next year. We may ask them to do it in 2 years' time. However, if the patient has a high risk, we may want for them to do it once per year because I've seen individuals with very low PSA 1 year, and then the following year, the PSA, rises tremendously. Where the DRE is concerned, initially when I see a patient, I will do a DRE and a PSA to screen the patient for prostate cancer. If the patient doesn't have anything to suggest that they may have prostate cancer, depending on their risk, I will oftentimes see them the following year. Now, I don't always do a DRE, all right? I will really just do a PSA and use the PSA as a guide subsequently, all right? But there's no specific guide to say, oh, you should do a DRE once per year or every 2 years or every 3 years. I usually do it initially when I see the patient, and then subsequently I do a PSA, and then maybe a couple of years after I may want to repeat the DRE again, but the PSA generally will suffice. If I see any marked change in the PSA, that is sufficient for me to proceed and maybe do a biopsy depending on the value of the PSA.
Thank you very much, Dr. Gooden. And just one other thing too. Could you shed any light on what the robotic surgery is about and when it's used? Thank you.
The robotic surgery is just another form of doing surgery, and it's essentially where they utilized a robot to assist in the surgery, but you're the one still doing the surgery, but you're a lot more comfortable. The robot be in the room doing the surgery. They already set up their different ports, and they can control this robot with a computer by being, in another room. But is the surgeon actually doing it? But the good thing about the robotic surgery is that they get very good magnification, and in actual fact, it's even a lot more easier because everything is now magnified, so it's a lot more easier. The problem with robotic surgery is that it's very expensive. And, we like to have robotic surgery, in Trinidad and in Caribbean, but the maintenance is ridiculously expensive. So if they were to have that, the patient would have to pay a whole lot of money to get that surgery done because of the maintenance that is involved.
Holy people, man.
Yes, Doc.
Let's see if we can wrap up quickly. So the guys who hands are up, let me see if we can wrap it up. So make a question quick and short.
So you're going by order, or we can just speak.
All right, go ahead, Mr. Johnson. Go ahead.
Okay.
Yes, Doc.
Dr. Gooden.
Good night. Yeah.
Am I on? I'm
Yes,
hearing someone.
Johnson, go ahead, Johnson.
Okay,
Hold on, Mr.
Good evening, everyone.
Yeah, good evening.
What could cause a 67-year-old person who does the test every 6 months to have a measurement of less than 1?
What would cause that person to have a PSA less than 1?
1, yes.
No, guess what?
Is it correct? Could that be correct?
No, yes, definitely. If more likely it's correct. I don't see a reason why it should be incorrect. If the person is not sure, yes, they could repeat the test, but having a PSA of less than 1 for a person who is 67, that is excellent. So many men would like to have a value like that, but if you're not sure,
no, it's not that I'm not sure about it, because the doctor says many men in the country would love to have a PSA like that.
Yeah, boy. I wouldn't even question that, boy. I will run with that.
Well, that happens to me. I am running with it. I was so elated.
Exactly.
I do my test every 6 months. Every 6 months I do test.
Yeah.
General test everything.
Okay, thanks, Mr. Johnson.
Okay, that's
Let's
Thank
go
you
with
very
Mr.
much.
Dave. Thanks, Mr. Johnson. Let's go with Mr. Dave, please. Quickly, Dave.
Hello, good night, Doc.
Yeah, good night.
Thanks for all the information. But I was just wondering, for enlarged prostate, what might be the cost for a surgery?
Where are you calling from?
Trinidad.
Okay. Now the costs vary depending on the institution, depending on the surgeon. The overall cost, including the institution, anesthesis, and the surgeon, it could vary from anywhere between 40,000 to 60, 70. It depends on the type of surgery. It depends on the surgeon. So that's the variation. So it could be as low as $40,000 for everything, or it could be as high as 70, 80. If you're doing laser surgery, that laser surgery is ridiculously expensive. So it could be like running over 100,000 for everything, or over 100,000.
Okay, thanks.
All right, let's go with Anthony Smith, please. Anthony Smith, quickly. Anthony Smith. Like he's not there. Let's go with Paul Yiping.
Yes, good night. Good night, Doc. Thanks for that information. Now, my question is this. What I was told at one point in time is that when you have an enlarged prostate, one of the things that they use to treat that is eat a lot of pumpkin seed, and the same thing that you mentioned a little while there, the saw palmetto formula.
Right.
What your take on that?
Right. So the saw palmetto, as I said, there are a lot of studies that have proven that it's not different from placebo. So what I mean is that you could drink water, it's just the same as drinking water. they haven't seen any major or significant change in your flow of your urine because of taking salprometo. Now with the pumpkin seed, with all my reading, I haven't seen anything where pumpkin seed can actually help with the urine flow. I have not seen though any studies on it that I could refer to say that the pumpkin seed doesn't or does have an impact on the urinary problem. So I'm not too sure about the pumpkin seed, but I've not read that before in all my reading, in all my literature reading. I've not read anything about the pumpkin seed.
Okay, thanks.
Showing Galaxy A12 21 is on. Where's Showing?
Good night.
Yeah, good night.
I just want to find out about like if going off every week or like every 4 days or 3 days normal. Because
that's what you're referring to. You're referring to what? Constipation, passing stool?
No, not constipation, because when I go off it has been normal.
Right.
But I also have a problem with my stomach. I'm not digesting food properly. The acid like this build up and it is pain on my back. And as we passing urine, dark, real dark. It is be burning sometimes.
Right.
You know? And I took tests, CT scans, I do the rectum tests.
Right.
You know, to find out what's going on. The push camera down my throat to find out, and all the tests come back negative. So I want to know, because you know when it's different organs, that's cause one thing to the next thing to the next thing. So I want to know if that's normal by going off like that, or if it's the acid digesting the food making that happen.
Yeah, I'm trying to understand the question. So I mean, so I'm a urologist, so I deal with like urinary problems. So I don't know, is your problem with the urine?
Well, it's like a twist gut.
A twist gut?
Yeah,
right.
I have a blockage between the gallbladder and the liver.
Okay.
The tracts called the ducts. They tell me one small that causing the others to expand. So I don't know if all of that causing me to not go off properly.
So go off mean what? Go off?
Like every 3 days, sometime a whole week I ain't go off. But when I do
go off, meaning what? Pass stool?
Pass stool, yeah. Defecate.
Right. Yeah. So that problem, all right, is usually a general surgeon or a gastroenterologist. You know, these are the ones that will deal with problems with the gut. Not a urologist. So I really can't give you much information on that. Yeah, you need to see a gastroenterologist or a general surgeon that could give you some more information on that. All right?
Okay. So let's move on. Elton, go ahead, Elton. Elton, let's make it quick, please. Elton, let's go with Peter Foster, please.
Good evening, Doc.
Yeah, good evening.
Okay, how effective is an executive profile where they use the stool to test for prostate, and right? They say you must use for prostate because that is on there too. You know, how effective is that test, and does proper diet can help control your prostate? Proper diet in the foods that you eat can maintain all of that and make sure your prostate stay intact and it doesn't enlarge. The foods that you eat, and can bad foods increase your prostate size and all of that stuff?
Yeah. All right. So I mean, good. I mean, good question. All right. So you're talking about the executive medical. That's what you're referring to?
Yes, a full body check for all different stuff.
No stool. I am not aware of somebody doing testing your stool to give you information about the prostate. But I know that you can put the finger in the back passage to feel the prostate, and that could give you information about the prostate. All right. There's nothing that I'm aware of that information where a stool could give you information about your prostate. Remind me, what's the other question you said?
I wasn't really saying if they do it, but I said executive profile that consists of all of this stuff, what they do. What would determine within an executive a full body examination, meaning the blood work and the urinalysis and all of that stuff? What will they use to determine? How could they determine if I have prostate cancer?
Okay, no, right. So with that executive medical, when they do the PSA, the value of the PSA may give you an idea depending on the value that you get when you do the blood test. The other thing that can be done is doing the digital rectal, where they put a finger in the back passage to feel the prostate. That could give an idea based on how the prostate feels to say that this is suspicious for prostate cancer. So those are the two things that they could use. Now they have other tests that they have used, a lot of other tests, because the PSA test is not specific. It's not specific for cancer. PSA can rise for various reasons. So they have other tests that they could use, but most of them tend to involve the PSA to help decide the probability of the person having prostate cancer. But generally, the PSA is one of the commonest tests that is still being used, even though that is not a sensitive or specific test to diagnose prostate cancer, but it is still one of the most commonest tests to still do.
Thanks, Doc. And I was talking about foods.
Oh, yeah, right, the food. No, I did mention before that generally people have eaten a healthy diet, meaning fruits and vegetables, the grains, nuts and stuff. Those are healthy diet. But there's nothing specific to say that if you do this or don't do this, you will either protect yourself from prostate cancer. But just to maintain a good weight, so if you're overweight, you try to lose that weight by exercising regularly and eating properly. But again, there is nothing specific. When you look at all the studies, there are occasions where they say certain things will help, and then another occasion they say that it won't help. There's a lot of stuff that has been made. The salpometer is something that they suggest. But if you read the fine print, they will tell you that you need to consult your doctor. But the problem is that a lot of people, when they hear the term herbal, they get excited, say this must be good, it's natural stuff, and they run for it. All right. But studies have proven, like the salpometer, that it does not, help you with enlarged prostate or decreasing the symptoms. As I said before, they have this thing called prostagenics. I really don't know much about it, but a lot of people have been, coming on the Facebook page, and you'll see commercials and these very big, individuals, who have high status that it helped. I really don't know much about it. I don't know if they have any scientific study on it as yet. It's something that I personally have to investigate to see if it helped. But generally, fruits, vegetable, lots of water, cut out your soda, keep a healthy weight, exercise as often as you can, and remember, always pray and trust God at the end of the day.
Let's go, Elton.
Sorry.
Yeah, let's go, Elton. Elton, you there? Okay, let's go with SS.
Yeah, good night, doctor.
Good night, sir. Good night.
My problem that I have is very low testosterone, and it causes the erectile dysfunction. I would like to know if that is associated with the prostate.
Right. So the testosterone is actually produced by your testicle, and for many reasons, your testosterone could be low. So when a doctor sees you and tests for your low testosterone, then he needs to see exactly why you have low testosterone. then depending on the reason and also depending on whether you're still interested in having kids, that will also determine your treatment. Now, one of the treatments for low testosterone, especially if you're not interested in having kids, is to give the patient testosterone. The symptoms will definitely improve in terms of one of the symptoms that you get when you have low testosterone is easy fatigability, no interest in sex. It affects your your erection, sorry. But when you take the testosterone, all of this changes. But what has been one of the concern of individuals is if taking this testosterone will cause them to get prostate cancer. So one of the things that we do as urologists is that we do the patient's PSA before, and we also do a diary to ensure that this patient doesn't have prostate cancer before we put them on testosterone. Now, a lot of studies have been done. They still need to do a lot of control large studies in order to find out specifically if testosterone causes prostate cancer. But it doesn't seem to, based on most of the what we call the retrospective studies, it doesn't seem to cause prostate cancer. But if the patient is diagnosed with prostate cancer, we need to treat the prostate cancer first before we put them on the testosterone. But we need to let the patient know that there is risk involved, and they need to understand this before they go on it.
Okay. What I observe is that one of the testicles, which is the left side, is very, very small compared to the right.
Right.
So I don't know if that is what linked to the problem, but one is extremely smaller than the next.
Right. So there's a lot of questions, that could cause low testosterone. And if your testicle is small, most men tend to have one testicle small, just like women have one breast smaller than the other. And as they get older, the testicle actually decreases in size, and that's one of the reasons why your testosterone level decreases as well, because it's the testicle that actually produces the testosterone. But when you go and see a urologist, they will ask quite a few questions to find out exactly why, because there are many things that could cause it. Your treatment, chemotherapy treatment could cause it. There's certain medication that could cause your testosterone level to go down. If you have infection of the testicle or both testicles, that could affect the ability for the testicle to produce testosterone. So they will ask you all these questions, and then they also do more hormonal tests to see, what could be the reasons why your testosterone is low.
Okay, thank you, doctor. I'll make an appointment.
Elton, is Elton there? Elton? No again.
Yes,
so Samsung
yes,
SM. Elton is there? Okay, go ahead, Elton.
Hi. Yeah. Yes, hello.
Elton talk.
Yeah, as the guy talk about the testicle, I had surgery on my testicle some time ago. I had hydrocele, and one was take out one, and where that is there now, does get so it does feel like tender, get a little pain there. Let's have that problem little off and on. Had check a doctor, and as the guy say, I want to feel which part the testicle there is feel like if it have one of the groins still just feel at that way. But, to me, that could be vertical vein. I'm not sure if that is correct.
Sorry, I didn't get that last part.
He told me that the vertical vein that came down or something as that.
What's that? I'm not hearing you. I get another feedback.
Vertical vein.
Oh, varicocele.
Yeah,
varicocele.
Right.
No, right. I haven't seen you, I haven't examined you, so I can't say for sure. But a varicocele is just an abnormal dilatation or widening of your veins, all right, that goes to your testicle. All right, that sometimes could cause discomfort, all right, but let's say you need to, like, if you have a discomfort and you're concerned about it, sometimes the doctor would order ultrasound on the testicle, because there are a lot of things that actually could cause a person to get discomfort in the testicle. But having said that, there are some men who have discomfort, and we could do all the examination, all the investigation, and still find, you know, no problem.
Okay. Yeah. I never did.
I have a question.
Hello. Yeah. I never did anything follow up on that, but I have prostate problem. The prostate enlargement, and
right.
yeah, and well, the same tablet that is talk about soap I'm into. Well,
Yeah.
I've been using that, and Flomax.
Right.
Flomax is what I use, and with the Flomax, I get from the hospital. You know, they give me the Sidapone, and that one, it is not as the one that you get in the drugstore. The one in the drugstore to me is the better one than the
Okay. We are approaching 10 o'clock, and we want to extenuate the doctor again for the evening. We want to call on Brother Ronald Peters to do a vote of thanks at this time. Thank you very much, Doctor, for your expertise and your time and your patience.
Thank
Ronald
you,
Peters, go ahead.
One more question. Are you ready to do one more question, Brother David?
Who said that?
One more question.
Thomas. Make it short.
Thomas.
Quickly. Make it quick.
Yes, sir. Sometime when it's cool weather. When it's cold weather, I find I pee a little more often than regular.
That's normal.
Or if I drink more than a gallon of water for the day, sometimes I find I pee a little more often in the night. I have to get up in the night to pee.
Right.
Or if I have to travel on an airline or something, because I find I pee a lot of sometimes in the airport. I have to be going to pee how much different time.
Right.
What is that? That's my question.
No, that's a question. Right. So
that's my question.
Right. So essentially, I mean, if somebody is peeing often, for example, say peeing often at nights, then we need to want to find out how many times at night that you're peeing. And then now we're going to ask a specific question to see exactly why is that the case. Are you drinking too much water at nights? Are you drinking, alcoholic beverage? Because remember, alcoholic beverage can cause you to pee often.
No alcohol.
Right. And there are other things like caffeinated beverages, like coffee.
None of that.
Lipton tea, Coke, Coca-Cola, and some of these sports drinks that they have, like the Glucosade, they have a lot of caffeine in them.
No caffeine. I'm an Adventist.
Okay. Well, I didn't know that, sir.
I'm just telling you. None of that. No alcohol. No.
Right. So there's a lot, and so I always tell people there's a lot of things that you may be drinking and that you're not even aware of. So I always tell patients, check the contents and see exactly what's inside these drinks. Because even some of the stuff they say is decaffeinated, I'm very wary of them as well. All right, very wary of them. All right, so it's important that you check these things. Now, the amount of fluid you drink is important. Generally, if you're a 70-kilogram man, you may require anywhere between 1,200 to 1,500 mils of fluid. Depending on the environment where you work, if you work in the kitchen where you lose a lot more heat, you may need to drink a lot more water. Or if you work on the road, always exposed to the extreme heat. Now, if you overdrink too much water, if you drink a lot of water, yes, you're going to pee often. So one of the things that we do when we see patients, we ask them to do what we call a bladder diary or avoiding diary. Like we ask them to measure like the amount of fluids that they drink, the type of fluids that they drink, and how often they pee. There's also other problems that a man can have. They can have what we call overactive bladder. All right, the overactive bladder is a bladder where they pee very often at night, pee very often during the day, and they also have what we call urgency, where they have to rush to the bathroom. And when they have symptoms like this, we call it overactive bladder. Now, we usually use behavioral therapy initially to treat such a patient, all right? But enlarged prostate in men can cause overactive bladder. So we have medications that we can also give them, all right, to treat that, because patients who are overactive blood, they pee often, but when they pee small volumes of urine. So there's a lot of things that you have to look at, and
Yes.
lifestyle, and and see what we can change, what we can keep, and see how things improve.
I'm from Jamaica. May I ask a question?
Okay, that's it.
I'm from Jamaica. May I ask a question?
No, we have exhausted all the time at this time, and we want to thank you all for your patience and so on. But we want to wrap up now. We have the doctor on for a while. So, Brother Peters, could you give the vote of thanks, please? Thanks.
So, everybody, you're hearing me?
Yes, Brother Peters.
Okay, first to begin with, I must say there's a lot of work went behind the scenes to present for this presentation tonight. A lot of work and a lot of people was responsible. But first, I would like to thank Almighty God through His Son Jesus Christ for giving us the foresight and the health and the strength that we could come together as men and have a discussion, and to give us the health and strength, and we can have a discussion which will be beneficial to each and every one of us. Okay, to our senior pastors, Reverends Lloyd and Norma Hart, also our assistant pastors, Bishop Anthony Roberts, Reverend Julien James, Reverend Andy Phillips, and Reverend Jacqueline Hart. Thank you very, very much for the support that you all give us to present this session. Also, special thank you to the men ministry coordinator, Brother Richard Hart, for the support. Also to the multimedia ministry of RevivalTime for assisting us in promoting this session. As you can see, we had over 500 persons on, and thanks to the multimedia ministry. Also, a special mention to the president of Power Men Ministry, Brother Haynes Fraser, and the executive and members. Thank you very, very much for your support in the proceeding to this. We know that we could have counted on their support, and we did get it, so which I thank you all very, very much. Also to Brother Randolph Ramuta, our RTA Med Ministry President, who worked tirelessly behind the scenes and who had the foresight to come in to form this concept of this mentor with prostate cancer, which is very informative, and the executive of the RTA Med Ministry. We thank you very, very much for your support, for your work behind the scenes to bring this session into fruition. To our doctor, Dr. Kirk Gooden, thank you very much, doctor, for taking the necessary time to, I know we in a COVID season and we're in a state of emergency and a lockdown, but thank you very much for giving up your time and your knowledge, inform us of this well, it's not a sickness, but this problem that affects men. Because listening to you, I have learned a lot. Sometimes you hear different concepts of it, but I am sure that I am the knowledge that I have gained tonight. I would not be listening to any myths about it pertaining to this problems that affects men. Our chairman for tonight, Brother David Mason, thank you very much as usual for a job well done. Thank you. We could always count on you. And to the men of the RTA Men Ministry, thank you very much for your support. Thank you very much for tuning in. And last by no means least, to all our guests who came on and who supported us tonight by listening and asking questions. We thank you. We have persons from overseas, from Jamaica and all different countries. welcome, and thank you very, very much. May God richly bless each and every one of you. I am sure this is just the beginning of something great that will be coming up soon. So please listen out for whenever we have anything coming up, and you all are most welcome. So thank you. Blessings to each and every one of you and your families, and have a blessed night.
Mr. Peters, will this be on YouTube? Will this be on YouTube?
Yes, it will be, son.
It will be on
RevivalTime
YouTube.
Assembly. You just go to RevivalTime Assembly YouTube page, and you'll be able to look it over again.
RevivalTime Assembly.
Yes, sir.
Right. Thank you very much. Yeah.
At this time, I want to ask Brother Haynes Fraser. Is Brother Haynes Fraser around?
Yeah.
Right. So, Brother Haynes Fraser, you close us off in prayer at this time. I want to, again, before Brother Fraser prays, I just want to thank Brother Dr. Gooden for the excellent presentation and the patience that he demonstrated in answering questions without flinching. It shows a passion for the work that you do. And please, as God will continue to empower you to reach out and bless men in this way. Thank you very much, Doc.
Welcome.
Go ahead, Brother Fraser.
Thank you, Lord. Father, we want to thank you for this very timely, vital, critical, very informative information provided in understanding prostate health. We thank you, Lord, for the information that provided. We have so many options in ways and means to respond to prostate health. And we trust God of the information we received tonight that we're going to use it, embrace it to really help us to promote and help us to stay healthy. We pray, God, today that we're going to bless your speaker, your servant, we're going to use him as he provides such vital, critical time information for men in terms of they're going to fulfill their fullest potential to serve God. Thank you. Thank you, Father. We give you all the praise, the Lord of glory, in Jesus' wonderful name. Amen and amen.
Amen.
Thank you very much, Brother Fraser. Once again, thanks to everybody who came in from the USA, from Jamaica, Trinidad, Tobago, rest of the Caribbean. We are very, very well touched this evening with the overwhelming response to this seminar that we had this evening. And we trust that the information garnered will be used for the betterment of the health of the men that are present on the site tonight, on the platform, and also
yes, thank you very much, Roger Bailey from Barbados. Very informative.
Thank you very much. So, and spread the word around. It's like evangelizing. Tell your brother, tell your uncle, tell your daddy about the condition that could occur if you don't manage the prostate well. So again, once again, from RevivalTime Assembly, Men's Ministry, and our fortnightly mentor, we want to thank you very much for coming out this evening, and God bless you all richly. Thank you very much.
Thank you.
Thank you.
God bless you all. God bless you all from Guyana.
St. Lucia. Thank you.
God bless you.
St. Croix. St. Croix.
Thank you from New York. Thank you.
Thank you, New York. Thank you,
God bless you.
Calling from Jamaica.
From US. God bless from Jamaica.
Thank you.
From Jamaica. Yes.
Thank you.
God bless. God bless.
God bless you from Barbados.
God bless you.
Very good.
Excellent job. God bless you, sir, from New
From
York.
Grenada. From Grenada.
God bless you all from Guyana.
Thank you, Guyana.
From Canada.
From Jamaica. Hope we can have another part 2.
Yes, definitely, definitely.
God bless you from the Bahamas.
Part 2 would be great.
Thank you for the Bahamas.
Good night, again. God bless.
Doc, let's do it again.
Blessings from Jamaica. Didn't catch it any at all. Would mind another session. Thank you.
Right, let's do it again, Doc.
Blessings from Trinidad and Tobago. Missed most of it. Got in on the
I love this Caribbean.
Thank you, thank you.
Next time you're doing it, you should have a YouTube connection as well, so that you can rewatch it on YouTube.
Yeah, you can go to YouTube and rewatch it if you wish.
What's the name on YouTube?
What's the link?
Revival
What's the
Time
link?
Assembly. It's Revival Time Assembly YouTube channel. So just type in Revival Time Assembly and you'll see it coming up.
Okay, thank you.
Thank you.
David, could you put that name in the chat, please?
And it's one word.
And put it in the
Yeah,
chat.
one word,
please.
Revival Time Assembly. Somebody type it in your
What's that again, sir?
Revival Time Assembly. One word. Revival Time Assembly.
Revival.
Revival. RevivalTime
Assembly.
Yeah.
Very good. Very good.
Thank you very much, sir. Do enjoy.
Thank you all very much, Doc. Well done.
Let's see.
Thank you, Doc. Thank you, Doc, from Jamaica.
Yeah, man. Thanks, man. You're most welcome.
Yeah, thank you, Doc.
Most welcome.
You love this.
It's on the chat. The link is on the chat. If you check the chat, you will see the link for the page for the YouTube.
Thank you very much, Doc. Excellent program.
Thanks. You're welcome.
Thank you very much, Doc, for the information. God bless you, your family from Guyana.
That's the link on the right. The links are right.
Michael Thomas from Jamaica. This show that men can come together for one common good when it comes to our health.
Amen.
Amen. Thanks very much.
Doc, write the link and down the tree for all could see link. That's coming up on YouTube.
Oh, yes.
Write the link.
I just sent the link just now. You could check it.
Check in the chat and you'll see the
chat.
Yes, right click on copy.
Right click.
I did shut. I did shut. There you go, Phil. Oh, me no know. Chat 22. Assemble. I see it here.
This is Revival Time Assembly, and the link is also there.
Yes, thanks, I saw it.
Yeah, welcome, you're welcome.
Yes, from Jamaica. I will miss it. Too much, over 500. So I come in the program late.
Sorry about that.
Thanks a lot, Doc. Thanks, blessing, many blessings.
Come on,
thanks, to you, brother.
Now, this proves to us that the medical missionary work will be the last work for God's people, that we can come together despite our geographical location, where we are in the world. Once it concerns our health and medical missionary, that will draw us together.
Amen, brother.
Amen.
Good night, Misha Krampi soon. God bless.
Link. YouTube. I'm going to sign out.
Right, blessed night to all. I'm from Tobago.
So it was a nice program by Dr. Gooden.
Thank you.
Blessed night to each and everyone. So next time I hope to log in.
Yes,
Thank you.
God bless. Have a nice one.
Yeah, Mikey.
Yeah, Mikey.
Yes, thanks.
You got him. Blessings, Peter Foster.
Can you all widen the platform to more than 500 persons? Maybe next time you all have any program.
So that will be a good in consideration. That's why they have this split up on the YouTube just to facilitate those who are not able to get home. So yeah, maximum I saw 167 persons on the YouTube. Where we are simultaneously 500 on the Zoom.
Oh, okay.
But we'll take it into consideration.
Avy?
Yeah, Richie.
I'm heading out.
God bless. Thanks for all your assistance.
No problem at all. Brother Amuta, have a good one.
Same to you, sir. Good night.
Night, night.
Blessings to everyone, man. Well done.
Good night.
From Narnia, there still?
Yeah, right here, David.
Okay. How the head going? Are they gone?
I didn't take any tablet this evening.
That was